Kong is ready to welcome you all again. It's time for all of us to say, Hello, Hong Kong.
Hello everyone. Welcome to the 14th Grand Round of Asia Pediatric Pulmonology Society or APPS. My name is Rina Triasih and I'm delighted to join you today as the president of APPS. As this is our first Grand Round of the year, I would like to wish you all Happy New Year. I hope the year ahead will bring good health, new opportunities, and meaningful progress for all of us, and most importantly, for the children that we care for. I would also like to take this opportunity to announce that the 11th APPS Annual Scientific Conference will be held in Hong Kong from 30 October to the 4th November this year. The meeting will feature outstanding regional and international experts, and there will be a wide range of interesting and exciting topics in pediatric pulmonology. So please save the dates, and we very much look forward to welcoming you all in Hong Kong. The first APPS Grand Round was held on the 26th of January 2024. So actually today we celebrate the second anniversary of this initiative. In a relatively short time, the Grand Round has grown into an active and well-engaged forum. We look forward to continuing this journey together. For today's session, I would like to express my sincere appreciation to the Emirate Thoracic Society for co-hosting and supporting the Grand Round. I would also like to acknowledge the effort of all today's speaker and moderator, and special thanks goes to Dr. Daniel Ng, who has coordinated the Grand Round since its beginning. Thank you. It is now my honor to introduce our moderator, Dr. Omendra Narayan. Dr. Narayan is a consultant of pediatric pulmonology and a sleep physician. He is the director of Pediatric and Sleep Lab of American Hospital in Dubai, United Arab Emirates. Dr. Narayan is also an associate professor of University of Sarat and Gulf University. He has wide experiences and research. With that, I will hand the session over to Dr. Narayan. Thank you again for joining us. I hope you find this session informative, relevant, and enjoyable. Please, Dr. Narayan. Thank you.
Thank you so much, Professor Reena, for the kind introduction. It's my pleasure to be the moderator today for today's session, and I have eminent experts as our panelists. So I want to introduce our panelists today for today's session, Professor Sushil Kabra. He's a former professor from AIIMS in India. Pretty much he doesn't need any introduction. I have learned so many things from Professor Kabra. And then we have Associate Professor Harutai Kamlapon, and she is a pediatric pulmonologist working at Ramthi Body Hospital in Bangkok, Thailand. And I had the pleasure of meeting her last year when we had our apps in Thailand. And along with her, we have Associate Professor Alice Siu, who's an ENT consultant. And it's our pleasure to have you on board for this session. And she is working in Hong Kong. Today's session will be presented by our pediatric resident, Dr. Hiba Al-Nidawi. She's a second-year pediatric resident working at American Hospital, and she's going to take us through a challenging case that we dealt last year or for the last couple of years who has been under our care. And the title for today's talk is Breathing Through a Straw, Tackling the Challenges. And as we come across different scenarios, our panelists will be taking over in the middle. Over to you, Dr. Hiba. Thank you so much.
Thank you, Dr. Omi. Good day, everyone. Today, I'll be presenting a case we have managed of a 13-year-old girl with a long-standing tracheostomy. I'll briefly cover her early history, her presentation to us, the initial findings, and the first decision point before handing over to the rest of the team. To understand why she presented this way at 13, I'll start with her early history. Okay. She was born with a tracheoesophageal fistula, laryngeal cleft, and an esophageal atrasia, all which required early surgical repair. In her first year of life, she underwent tracheoesophageal fistula repair, laryngeal cleft repair, cardiac surgery for atrial septal defect, and multiple airway and esophageal endoscopies. Because she required prolonged ventilation and ongoing airway instability, a tracheostomy was placed at 3 months of age, and over time, it became long-term. She had one attempted decannulation in India at around 7 years of age, which, according to her parents, was unsuccessful, and no further attempts were made for several years. Although initially it was life-saving, the tracheostomy gradually became long-term. Fast forward to when she first came under our care at the age of 13, she was referred to us due to recurrent chest infections. She presented to us at 13 years of age with pattern of recurrent chest infections and chronic wet cough. At presentation, she had a Shiley 3.5 tracheostomy in situ, which is a neonatal-sized tube, cuffed but deflated without a speaking valve and providing minimal effective airway support. She could vocalize when occluding the tube, but her voice remained muffled and soft. Because this has been ongoing for several years, the family had naturally adapted to what her baseline looked like. On examination, the findings supported a chronic process rather than an episodic infection. Her growth assessment, she was tracking along the 25th centile, indicating adequate nutrition despite chronic disease burden. She had a consistently soft, muffled voice quality even when attempting to vocalize with the tracheostomy occlusion. On her respiratory examination, she had a productive wet cough with noticeable secretions, bilateral coarse crackles on chest auscultation, diffuse expiratory wheeze, and there was no digital clubbing observed at that stage. And here, our priority was twofold: reassessing the airway and optimizing her lungs before any major airway decision. The first step was a complete airway reassessment, mainly a bronchoscopy and a flexible nasal endoscopy. We wanted to define her anatomy, assess dynamic collapse, and check for any granulation tissue. In parallel, we focused on pulmonary optimization because she had chronic suppurative lung disease, so airway clearance, physiotherapy, and treating infection were key before considering any decannulation pathway. This naturally led us to a stepwise approach, starting off with a complete airway reassessment, optimizing lungs, and assessing her readiness, to only then considering a decannulation attempt. This approach was meant to reduce risk, especially in a patient with limited reserve and a complex airway history. Bronchoscopy ended up a turning point in this case. Her bronchoscopy showed marked tracheomalacia with severe dynamic collapse extending from the tracheostomy tracheostomy site down to the carina. There was no bronchomalacia reported. Her airway also collapsed in the absence of the tracheostomy tube, which to us suggested that it was acting as a stent. In addition to all of that, both vocal cords were immobile in a pyramidian position with minimal abduction, creating a severely restricted glottic aperture. Here's a video of a flexible nasal endoscopy and bronchoscopy. showing us a bilateral vocal cord palsy. All right. With that background, the next step was to assess whether decannulation could be attempted safely. At 13, we decided to go for a decannulation attempt under our care. As part of the pre-decannulation assessment, she underwent a CAP tracheostomy trial and overnight oximetry before the planned tube removal. Throughout the CAP trial, her oxygen saturations remained stable, averaging around 95%. Overnight oximetry showed an oxygen desaturation index of 3.6, which would be suggestive of mild obstructive sleep apnea. She was also able to tolerate a prolonged capped period of around 10 hours without physiological compromise. Overall, from an objective physiological standpoint, the pre-decannulation assessment appeared reassuring. However, the unexpected outcome here, despite reassuring physiological parameters, decannulation could not have been done. On the day planned for tube removal, she became extremely anxious and expressed a strong fear that she would not be able to breathe without the tracheostomy tube. At that point, removal of the trach would have unmasked dynamic airway collapse from the underlying tracheomalacia. That physiological instability, we're not sure if it has heightened the anxiety that she has already had. So although everything looked reassuring, we could have not gone for the decannulation. This unexpected outcome shifted our focus from asking, can we decannulate, to what needs to change before we safely can. Moving on to our poll here, I would like for you to put the answers. Question is, what are the factors that improve chance of decannulation of tracheostomy tube? Use of speaking valve, use of CPAP, capping of tracheostomy, or all of the above? I'll let Professor Alice talk on this further from here.
Thank you, Dr. Heiber, for your kind introduction. So we can see from the video that the airway is quite congested with quite a lot of mucus. It is probably related to the underuse of the upper airway. And so right now there is about 43 of the participants that have voted on what are the measures that can improve the chance of decannulation. And I will say most of you use other weapons. The use of speaking valve and CPAP and capping of the tracheostomy are both considered as viable attempts, and many of you will consider all three. So, so the result is shared. Yeah. So, I am Alice, and I am going to talk to you about what are the possible ways that ENTCs as the fail of decannulation. And there are two factors that we can identify in this case. Is one of it is a possible case of tracheomalacia, as Dr. Heiber has pointed out, that with the tracheostomy and catheter, the patient was relatively well. So she has some sort of standing helps her to maintain the airway, while removal of such a physical existence of a stent led to desaturation and failing of the cannulation. So please change to yes. So we have two questions on our mind. Is the tracheomalacia a cause of the decannulation, or is it a consequence of prolonged intubation? Is it the reason why the patient had the tracheostomy in first place, or now it is an exacerbating factors of failing the decannulation? And the second question is whether the laryngeal finding of impaired mobility is truly of any significance in terms of affecting the decannulation. It possibly not, because with the capping, the patient is relying on the laryngeal airway anyway. So I thought that it may be contributory. So when the patient has a tracheal tube, inside tube, they can have multiple causes or reasons why they can acquire a tracheomalacia, being the segment of the tracheostomy or downstream, and what we call downstream tracheomalacia. And this is what we call acquired tracheomalacia, and is commonly iatrogenic due to cuff pressure of the endotracheal tube, or another reason is multiple causes, because the cuff can contribute to it. And another thing is the multiple repeated clearance of secretions by traumating the mucosa, and also the distal way may lead to chronic inflammations in the distal trachea that may weaken the cartilage itself. And for patients with a prolonged disease, such as in this girl, there may be critical illness related to tissue fragility. And another one very important thing that is the bypass of the glottis lead to the loss of physiological conditioning, and the breathing without the glottic resistance lead to a constant breath by breath collapse of the lower airway, which is weakening the cartilage itself. So there are multiple contributory mechanisms that can lead to these kind of acquired tracheomalacia at the segment and distal to the segment of the tracheoplasty and the tracheostomy. And the thing is that we are not sure how much each of these factors can contribute to the outcome of this patient's manifestation. And as a ENT and pulmonologist as well, the correct work as done by the managing team is flexible bronchoscopy. The bronchoscopy not only going through the tracheal tube to downstream, but also to the nasal airway, to the glottis, and also to the subglottis areas to look at different segments of the airway. And another possible investigation that we can do is dynamic CT and spirometry. And these are possible findings of the trachea that is commonly associated with prolonged tracheostomy. You can see on the left side is what we call the A-frame deformity. It's when we perform a tracheostomy, very often, especially in pediatrics, we want to pull the skin close to the trachea so that there is the least chance of force tracting at the time of bedside management. So if a child had a very young tracheostomy, they are growing, have the trachea cartilage growing attached to the skin, it can cause a deformity at the growth of the cartilage itself. You can see it's like the A shape or a triangular shape. It can sometimes be very sharp, and sometimes even evolve into stenosis. Can be from cuff results, can be from pre-existing intubation, but also because of the tracheostomy itself. And another important factor is the one on the right, what we call supraglottic granuloma. or supraglottic flap is also because the child had a tracheostomy done very young. We push a little bit of cartilage inwards to the luminal of the trachea. So it grow with the child and it become a cartilage flap. And sometimes because of the repeated foreign body stimulation, granulation grow on it as well. Also a migraine infection and become a granuloma, just a very tough, hard piece of tissue that is obstructing the supraglottic airway that is slightly above the tracheostomy. So when they assess or reassess the airway, we not only look at the distal and the vocal cord, but also look at the tiny segment that is below the vocal cord and above the tracheostomy. So the management of this kind is we remove what we can see. And of course, if there are ongoing injury, we optimize the airway. If there is a cuff, we try to not use the cuff, humidification, secretion clearance, downsizing the tracheostomy tube sometimes can help. But in this case, a 3.5 in a 13-year-old may be too small. So a tracheous tube that is too small sometimes cause more irritations to the wall as well. And a very important trick is to restore the glottic pressure. So it is from a physiological point of view to restore the slight airway resistance so that the glottic pressure is maintained. And if the patients can tolerate it with times, a speak cutting or capping trial, despite may not be successful in the first place, maybe is a treatment trial that can help the patient to adapt to breathing with slight resistance. Of course, we can, give resistance by giving positive pressure from above. But if you have a tracheostomy, whether you apply the airway from the upper airway or at the stoma is a possible different approach to how do we give pneumatic standings to the airway. And of course, we can do endoscopic surgeries to remove things or to stabilize the airway, such as stenting, or eventually some of them will require tracheoplasty or even more aggressive open chest surgeries to stent the airway. And as on the management by most of the pulmonologists, speaking valve and speaking exercise is not only giving the voice to the patient, but it also restore airway physiology rather than just testing obstruction. The mechanisms are the speaking can restore expiratory flow through the glottis, reestablish some of the glottic pressures, and improved cough efficiency because of the presence of the glottis will improve the patient having spontaneous secretion clearance, therefore reducing the burdens on airway trauma and suction, and also enhance the swallowing airway coordinations because the patient now learns to take deep breath while they want to inspire. And it functions as a graded functional readiness for decannulation. And we can also monitor the pressure when the patient happens speaking valves inside you, kind of predict what is the resistance either at the lung or at the upper airway when they want to decannulate. So how it works is that we have to appropriate downsize the patient. Usually half a size is adequate or one size is adequate. And then allow some of the airflow, approximately half of the flow can going through the original upper airway. And we have to make sure that the upper airway is patent mechanically. The nose is obstructed by adenoids. If there is any secretion or any other like polyps, they are well treated off. And of course, the subglottic granuloma or flap we have already taken care of. And there is no downstream risk. I put down bleb and bleeding is that some of the patient has very delicate blood vessels downstream or granulation tissues, or because of pulmonary insults before, they have a cyst or thin wall cyst or flaps in the lung that may predispose them to pneumothorax if they have an increased subglottic pressure. So they don't have a downstream risk. And because training of the airway, upper airway especially, is not something that can be achieved instantly. So patients, to allow the patient to try, and the faith to explain to the parents is also keys. And a very often question is that whether fenestration will help. And I would say yes for most of the case, especially in adults. But the fenestration hole has to be exactly at where it should be, at the subglottis, and then you can see the hole and therefore breathe through it. And it is rather difficult in most of the pediatric cases because of the various skin thickness and sizes of children. So fenestration only works in selected cases. So the second caption comes with a vocal cord palsy, and we can appreciate that quite beautifully with Hyper's video. The left side is definitely a palsy because we also know that TEF repair will use either approach. They will have to enter the tracheoesophageal groove. So they are very prone to damage the left side. But the right side, are we sure? We're not actually the evidence tell us that the patient can speak with some voice, and the other way is that with capping and with her laryngeal airway, she can quite manage. So another way is seeing it is probably because of the prolonged use of the tracheostomy. There is a possibility of what we call pseudopalsy. It is because just like any other muscle, the muscles are so underused that it feels like the muscles are tight. But in Hyper's video, we can definitely see there are some flickering movement on the right side. So the vocal cord palsy on scope may be a case of true neuropathy, but more likely to be intubated related or prolonged underuse related immobility. Last, how we distinguish them, we use laryngoscope, we use evidence from what we had in different assessment, or in some of the centers, very well equipped laryngeal EMG can be of use. So this is the last slide, ENT perspective on difficult decannulation. Speaking valve and CPAPs are very useful tools, and occasional cases may be escalated to stent or surgery. So thank you.
Thank you, Professor Alice. That was very informative. Now, moving on from our initial deferred decannulation, our focus now was how to reduce chest infections. To do that, we wanted to continue optimization rather than going for another immediate attempt. This included ongoing chest physiotherapy, as we can see here in the video.
Ready, guys?
Yes.
Okay, let's go.
Breathe in, breathe in, breathe in.
Good, and another one.
For that, and targeted antimicrobial therapy for chronic colonization and close multidisciplinary team. Despite that, it became clear that optimization alone was not enough to overcome the underlying airway instability. Removing the tracheostomy tube without addressing the underlying malacia, the chest infections, would likely give us the same physiological limitation. This led us to a broader discussion about how to support the airway in a reversible way. We discussed this case extensively with a multidisciplinary team, and the consensus was to go for tracheal stenting. It offered a reversible strategy to support the malachic segment and simulates airway patency without the tracheostomy tube to allow us to reassess for any further decannulation attempts. Importantly, this approach avoided committing her to any definitive surgical intervention at that stage. With this plan agreed, we proceeded with the tracheal stenting. In this video, you can see a temporary tracheal stent being placed It was mainly to support the infrastomal segment extending toward the carina. And at the same time, we're removing granulation tissue, which visibly expanded the airway lumen. Us removing the granulation tissue, and you can slowly visibly see how it opened up the airway lumen. This is the tracheal stent placed. We used organ plasma coagulation, ablation with that as well. Following that, her clinical course changed and improved remarkably. The stent was removed, and a repeat airway reassessment was also done with a bronchoscopy, and it has improved remarkably with reduced tracheomalacia. And this allowed us to reassess for her readiness for another decannulation attempt. At this point, several things had come together. Anatomically, her airway was more stable. Medically, her lungs were optimized and infection burden was controlled. Psychologically, she had gradually built confidence through prolonged capping and no longer associated tube removal with distress. And practically, the family and the multidisciplinary team were fully prepared. With all these factors addressed, we proceeded with the decannulation, and finally, the tracheostomy tube was removed. She tolerated the procedure well without respiratory distress or desaturation and was able to maintain proper ventilation through her native airway. For the first time since infancy, she was breathing comfortably without a tracheostomy tube. Our post-decannulation course was focused on close monitoring rather than intervention. This includes surveillance for residual tracheomalacia, management for any aspiration risk, performing spirometries, and speech rehabilitation, which showed significant improvement of speech. But one of the most important key elements here was ongoing airway clearance, because it did remain the mainstay. And that wasn't because of decannulation itself. It was because already she had established bronchiectasis by the time she had come to us. And here we have shown two CT images, both of them showing bilateral bronchiectasis with air trapping and mosaicism. In here, you can see a dilated bronchus adjacent to the pulmonary vessel, which confirmed chronicity. And in figure 2, you can see flattening of the airway, which was suggestive of malacia. Professor Sushil will go into bronchiectasis into more details today, so I won't do so. What we wanted to understand was how this translated into functional lung performance over time. So we have performed spirometry for her, and it was after the decannulation. On the left was from July 2025. Her FVC was around 60% predicted, with a preserved FEV1 to FVC ratio of 86%. This was consistent with restrictive pattern, but we could have not ruled out fully obstruction as we did not do the total lung capacity. On the right, from January 2026, which was actually 2 days back, her FVC was at around 62% predicted, and her FEV1 to FVC ratio was around 80%. So evidently here there was no deterioration since the decannulation was done, and she remained stable. Looking back at everything mentioned till now, it raises an important question like this: which intervention has had the greatest impact on preventing bronchiectasis relapse in this patient? I'd appreciate you sharing your answers. And this brings us perfectly to the next part of the session with Professor Haritai.
Okay, thank you, Hibat. I would like to congratulate on your hard work, and you and your team done a wonderful job. Yeah, so finally, the kids comes off the tracheostomy with a successful decannulation. Okay, and interestingly, for the poll answer, we are talking about bronchiectasis and what happened and how to prevent it. So most of the answer, the audience answer about airway clearance and antibiotic prophylaxis. Yeah, okay. We will come back to the answer later on. So I would like to present my perspective about the complex airway and aerodigestive disorder in the kids after TE fistula repair. Okay. Okay, so most of the bronchiectasis that we are usually we always hearing about infection that is the cause of the bronchiectasis with the vicious cycle of the inflammation, infection, initial infection, inflammation, and impaired mucosal clearance and airway mucus hypersecretion, obstruction, and then it's come as a cycle like this with the bronchial airway dilatation. But this is the special case that I would like to move on. Okay, usually for the kids with the TE fistula repair, it's not only the infection itself, it's not inflammation, but it becomes about the risk factor about the structural airway disease with the aspiration and the clearance failure. So with the chronic infection and inflammation and airway remodeling occur that leads to the bronchiectasis in this case. So the respiratory morbidity in children with GE fistula was previously reported in many evidence bases. And this is the bronchoscopy appearance about tracheomalacia that you actually show already, and the bronchiectasis in the CT scan. So usually it can occur because of the aspiration, because the damage of the esophageal and tracheal innervation. This is the kids with structure failure since congenital. So this can cause the immature or abnormal VGF or mediated signal. So it can cause abnormal development of airway and lungs with the laryngeal cleft, with the star that we have in this case. Recurrent E fistula may occur. And once again, I found tracheal pouch in one of my patients after TE fistula repair. This is the nightmare I told you. Okay, and tracheomalacia, bronchomalacia, leading to impairment of the mucosal clearance itself, leading to bronchiectasis. Also, aspiration and dysphagia, GE reflux, and esophageal stenosis, vocal cord paralysis may occur as in this case as well. So these all are the risk factors leading to bronchiectasis. It's not only infection. Okay, so for the aerodigestive disorder, on the left-hand side is about the lungs. On the right-hand side is about GI. For the lungs, the bronchiectasis as a complication of recurrent aspiration from anatomical laryngeal cleft, recurrent E fistula, vocal cord paralysis, dysphagia, and GERD. But on the right-hand side, with the aspiration, it may have feeding difficulty as well. Dysphagia, the kids may feel like they fear to swallow because of the esophageal stricture occur, and then it might be an eosinophilic esophagitis leading to GERD or the dysmotility itself. All of this leading to aspiration. So this is the interview for the focus group of the parents of the kids with esophageal atresia TE fistula, aged 6 months to 7 years old, with the children's symptoms experienced. So what they report was the respiratory symptoms combined with the digestive symptoms, breathing difficulties, cough, mucus problem, prone to frequent severe infection in the respiratory tract, reduced physical capacity, heartburn, hiccups, nauseous, and reflux, vomiting throughout, and swallowing difficulties. And with the feeding difficulty, they may have food refusal and restrictive selective eating, upset with their feeding, and need for adaptation during the meals. These are from the real world feelings of their parents, and they report that. For early identification, the red flag signs are long-standing tracheostomy, like in our case, and failed decannulation, tracheomalacia, vocal cord palsy, recurrent wet cough, recurrent pneumonia, swallowing dysfunction, and GERD. So how to prevent bronchiectasis depends on early recognition, as I mentioned about the red flag sign already, and integrated aerodigestive care is the key. So the answer from the audience poll, my question about how to prevent bronchiectasis in this case is to about the aerodigestive care or evaluation. How? So with dysfunction, swallowing assessment, with the clinical, as I mentioned before, poor weight gain, GERD, chronic cough, recurrent pneumonia, and then we need a multidisciplinary assessment with the speech and language therapist, bedside assessment, oral motor control, fatigue, and some tool that we might have to do, like a VFSS, mean the video fluoroscopic swallowing study to see how the aspiration occur. This is the flu, so we can see the picture and the movement of the fluid or the milk or the food that the kids intake during the study. And with the V, that means fiber optic endoscopic evaluation of swallowing to see laryngeal cleft and is there any aspiration from above. And so with the swallowing assessment like this, we can identify the etiology and integrate the management for kids. So for the advanced in pediatric esophageal atresia and TE fistula, they recommend to do the triple endoscopy. What triple endoscopy means? The triple endoscopy means the aerodigestive team referral with the flexible bronchoscopy with BAL, which should be done by the pediatric pulmonologist, with the MLB, the microlaryngoscopy and bronchoscopy, which could be done by the ENT doctor, and the esophageal gastroduodenoscopy or EGD with the biopsy, plus or minus the impedance with the pH probe. Under a single anesthetic event, 3 doctors do the triple endoscopy altogether with a comprehensive evaluation. And we come up with a plan. So this is the sequelae of the finding from the triple endoscopy after TEF repair in the children. So most of the findings are about the GERD and tracheomalacia and laryngeal cleft. So our case is quite common. I think our case may have some aspiration from reflux. And which aerodigestive model, you combine many specialists all together and we coordinate. Even if the long term, this is not only the problem with the children or in the young age only. So this is the international network on the esophageal atresia consensus guideline in transition patients from esophageal atresia and TE fistula. They recommend to evaluate from the symptom first and evaluate for aspiration. If you suspect about laryngeal cleft, you do rigid bronchoscopy. With about this motility or aspiration from above, you do the upper GI series, upper GI manometry, and observe the swallowing assessment. With the recurrent TE fistula, you do the bronchoscopy with the pullback study. With the GERD, you do upper GI endoscopy, manometry, and the pH probe. And the CT scan to identify the bronchiectasis. So this is the picture about the esophageal gastric junction dynamics, which they mentioned about the measure the impedance manometry to identify the dynamic of EG junction, and they can identify aspiration. And the long term, with the huge cohort study, they found that GERD still occur even if the child enter adolescence. And esophageal stricture, tracheomalacia still going on. So integrate aerodigestive follow-up is needed to position the bronchiectasis at the long-term outcome. So TE fistula is not only the neonatal surgical disease, it's a lifelong aerodigestive disorder, and the bronchiectasis prevention require early integrate. And this is the early and middle and the late phase. And our goal is to prevent irreversible airway remodeling. Thank you.
Thank you, Professor Haratai. That was very helpful. All right. Now, moving on beyond imaging and spirometry. Oh. Okay. We also wanted to understand how all of this translated into a real-world functional capacity. Her 6-minute walk distance, 6-minute walk test was done, which showed a distance of 401 meters, which is around the third centile, which is below the expected range for her age. However, her perceived exertion remained very low on the Borg scale, and her heart rate response was blunted. Putting this all together, this suggested deconditioning rather than any cardiopulmonary limitation. This was an important finding as it showed that there was a need for rehabilitation rather than escalation of respiratory support. Alongside the functional assessment, we addressed the infectious component of her bronchiectasis. Her peak cough flow was at 22 liters per minute. Her sputum culture showed Pseudomonas aeruginosa growth intermittently, consistent with chronic airway colonization. She was started on IV piperacillin tazobactam and alternating cycles of nebulized colistin and tobramycin for 3 months, which eradicated the Pseudomonas. And at this point, we've talked about airway clearance, functional status, and chronic infection, which led us to this question. Management of non-cystic fibrosis bronchiectasis includes all the following except regular airway clearance, aggressive treatment of Pseudomonas identified in airway samples, inhalation of hypertonic saline to enhance airway clearance, inhalation of DNase as an adjunct to airway clearance, or inhaled antibiotics. I'll hand over to Professor Sushil.
Thank you. Namaskar and greetings from APPS in India. I'll take you through the exact answer for this audience call is inhalation of DNase as an adjunct to airway clearance, and we'll be discussing in next few slides that why I'm suggesting that no DNS is to be given. Otherwise, regular airway clearance, aggressive treatment for Pseudomonas, in hypertonic saline, as well as inhaled antibiotics are recommended for management of non-CF bronchiectasis. In Asia, we respirologists come across non-CF bronchiectasis more often than CF bronchiectasis. And our index case had a Pseudomonas in the airway, and the treating team gave a good eradication treatment. So, why Pseudomonas is so important? Because colonization with Pseudomonas is associated with rapid decline in pulmonary function and damage. Aggressive treatment of Pseudomonas improves outcome by reducing exacerbations, improvement in pulmonary function test, as well as nutritional status. And these are based on the randomized controlled trials in adult patients and studies done in cystic fibrosis. And management of Pseudomonas consists of surveillance culture of airway secretions that you do repeatedly whenever the patient is attending your clinic, aggressive management on identification of Pseudomonas first time, and management of chronic Pseudomonas that I'll be discussing in detail. And treatment consists of systemic as well as inhaled antibiotic and of course airway clearance. And the determinant or the factors which determine how to manage Pseudomonas is from where you have collected it, whether it was a upper airway sample or lower airway sample, whether it is the first time or it is going on repeatedly, symptomatic or asymptomatic, and whether there is a feasibility of obtaining lower airway samples like sputum, induced sputum, and bronchial lavage. Other important determinant is available antibiotic, cost, and compliance. Oral antibiotic, which is available to most of us, is ciprofloxacin. Otherwise, you can use intravenous in form of piperacillin tazobactam as our index case received, cefoperazone sulbactam, ceftazidime, etc. And inhaled antibiotic like tobramycin and colistin. So now, how to go about it? Once there is a Pseudomonas, if it is from the upper airway, like cough swab or throat swab, in that case, we try to document lower airway sample. If that is not feasible and child is asymptomatic, then no treatment, keep under follow-up, try to document in the repeat sample. If it is possible to do a lower airway sampling, child is symptomatic and positive, then you give oral ciprofloxacin inhaled antibiotic for 2 weeks, followed up repeat sample. And if it is already you have taken a sample from lower airway secretions like sputum, induced sputum, or bronchial lavage, then you give an antibiotic intravenous, one or two combination for 2 to 4 weeks. Along with that, inhaled antibiotic for 2 to 4 weeks, and then you do a repeat sampling. If it is persisting, then you decide about treatment as a chronic respiratory colonization. When you are treating it, there are a frequent questions like, can I use injectable preparations when I do not have a, a, a inhaled preparations of gentamicin, tobramycin, or colistin? So answer is there are some experience with injectable antibiotic being used as an inhalation, but no randomized control trial. And the doses are 80 to 160 people have used milligram of Zenta or tobramycin twice a day by nebulizer, preferably using a mouthpiece, as inhalation by mask may be associated with some nasal bleed. What regime I should follow? Extrapolated from experience with the cystic fibrosis, it may be 2 to 4 weeks, followed by 2 to 4 weeks of till at least two consecutive cultures are negative. Then role of DNAs in non-CF bronchiectasis. There is no evidence to support improvement in a non-CF bronchiectasis, though it is a known treatment for CF bronchiectasis. One RCT showed a worsening of clinical condition. Therefore, as of now, they should not be used. Breath actuated nebulizer. There are some smart nebulizer. The deposition is considered to be better if you use a breath actuated nebulizer, but there are no RCTs to document it. How to prevent risk of contamination and colonization of nebulizer? There is a significant risk of colonization and transmission of infection to other children. Better to use patient-dedicated nebulizer, not to be used by others, and cleaning and sterilizing periodically. And appropriate duration of inhaled antibiotic, fixed time or till drug finished, then better to give it till the medicine is finished in the chamber of nebulization. So the other mainstay of treatment is airway clearance therapy, and there are sufficient evidence that airway clearance improves the outcome, but it remains neglected. So, what are the types of airway clearance technique? Manual technique, breathing technique, and mechanical devices. So, most commonly, we are aware and well conversant is the postural drainage, in which gravity assisted airway clearance is facilitated by clapping and vibration during the expiration. Time may vary from 3 to 10 minutes in each standing position, to a total of 20 to 30 minutes. Head low position should be avoided if there is a risk of gastroesophageal reflux disease, and these are various positions which we use. So in infants, it can be done by the mother when the infant is in the mother's lap in the same way. Then percussions are rhythmic force applied with the cupped hand over the involved area during both inspiration and expiration. And you can use these devices or you can use your fist. Then there is a high frequency oscillation vest. This is inflatable vibrating vest, helps dislodge mucus and move it into the larger airways. This is the type of vest. The vest is used in conjunction with the huffing to release the mucus. Then there are positive expiratory pressure therapy like PeriPEP, MaskPEP, and TheraPEP, which are available and low cost in these devices. Then some are the oscillating, like you can use uh, this thing Flutter or a cappella. The principle remains same, and they are small portable device and less expensive than the West. And then the last one is, which is less expensive, is it is frequently called bubbles pep, as the creation of bubbles by the addition of fluid, detergent, and food coloring to the water. In and you can increase the water depth with increase the pressure and decrease oscillation during the expiration. And this is easy to make and less expensive. So to summarize, take medications correctly using the right technique in the correct order with relation to other airway clearance strategies. Maintain good hydration so that the secretions are not very thick. Daily aerobic exercise at the appropriate intensity. Daily airway clearance, that is most important mainstay of treatment for all non-CF bronchiectasis, and use adjunct if child has asthma, bronchodilators, mucolytic agents like 3% or 7% saline, 3 to 5 milliliter in each session, and not to use DNS. Thank you very much.
Thank you so much, Professor Cabra, for summarizing it very nicely, the evidence around management of bronchiectasis, which is very, very common for most pediatric pulmonologists. So we have come to an end to our session. I just want to summarize, and I want to say thank you to all our audience for nicely listening to this session. Thank you so much, Hiba, for excellent presentation. Thank you to our panelists, Professor Harutai, Professor Alice, and Professor Cabra. And I must say a huge thank you to our admin team, Persist, and above all, Professor Daniel for coordinating everything. This is our team. You can see the girl over here. That's the mom, our physio, Helen. And this is our speech therapist. Now, if we see the video, how she's singing now and how her voice has changed. Sorry, I've already gone to the next slide. So if I have to take home message, if I talk about take home message from this complex case, what I want to summarize is that this child was born with a complex airway problem that ended up getting a complex bronchiectasis as well. And if only we would have intervened early, could we have prevented bronchiectasis? We don't know, because it's, as you have seen by Professor Harutai, it's a complex phenomenon. Despite your best efforts, they can develop bronchiectasis. But the win-win situation in this case was we were able to decannulate. She's going to mainstream school. She's having an excellent life. But the journey does not end up over here. We need to have continued multi-speciality input from our aerodigestive center or clinic, including gastroenterologists, ENT specialists, dietitian, physiotherapist, and so on. So as a teamwork, if we work together, any complex things can be solved with an excellent outcome. So I would like to thank you all once again. Moving on to next slide. I just want to invite you again to Hong Kong, which Professor Reena already mentioned about, that in end of October and beginning of November, we will have our conference of apps over there. So please do join us in Hong Kong. And please do join us in end of March, on 29th of March, when our Korean team is presenting on, and they are talking about an apneic infant, and they will talk in the grand round. So thank you all. Have a wonderful weekend and see you soon. See you next month or in the March. Bye bye.